वो ठीक है, बड़ा वाला जो किए हैं ठीक है वो।
जी, गुड इवनिंग सर।
गुड इवनिंग, गुड इवनिंग, गुड इवनिंग। उन्होंने दिया, भेजा?
नहीं भेजे हैं सर।
बोले कि भेज रहे हैं। गुड इवनिंग सर। हाँ, डॉक्टर सुधीर का सेशन है, 2 मिनट के लिए जोड़ लीजिए। ठीक आ जाएगा। अच्छा अच्छा, जी सर। स्लाइड शो में करिए। स्लाइड शो में डालिए उसको। गुड इवनिंग सर। अनम्यूट करिए सर, अनम्यूट।
हाँ, कर लिए कर लिए कर लिए।
एक तो बहुत अच्छा काम किए सर।
क्या?
चेयरपर्सन चेयरपर्सन सबको फ्री कर दिए रजिस्ट्रेशन।
आ,
चेयरपर्सन को फ्री रजिस्ट्रेशन कर दिए एपिकॉन 2026 में।
चेयरपर्सन नहीं भाई, चेयरमैन
हाँ
को, चेयरमैन को एंड सेक्रेटरी को।
हाँ, तो वही चेयरमैन 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 एंड सेक्रेटरी को, जी जी।
लिस्ट आएगा तब, अपने से नहीं।
जी जी।
लिस्ट चाहिए।
जी सर। ना, ब्रांच सेक्रेटरी और चेयरमैन को भी।
नहीं नहीं, स्टेट को, स्टेट को।
नहीं नहीं, वो तो पॉल तो बोल रहे थे कि ब्रांचों को करवा रिक्वेस्ट करेंगे।
ना ना, स्टेट।
नहीं नहीं, स्टेट को तो चाहिए, ठीक किया सर।
हाँ।
डॉक्टर सुधीर आप ज्वाइन किए क्या? डॉक्टर सुधीर आनंद, ये स्लाइड जो है डॉक्टर सुधीर शेयर कर रहे हैं क्या, आप कर रहे हैं? इसको स्लाइड शो में डालिए सुधीर जी। 3 मिनट बाकी है।
से पता चलेगा हमको। तुम रहो भाई, तुम हो गया सर।
स्लाइड शो ये करिए।
हेलो।
स्लाइड शो में नहीं है ये अभी।
मैंने तो शेयर किया है पूरा स्लाइड।
नहीं नहीं, स्लाइड शेयर है, स्लाइड शो एक फुल स्क्रीन वाला होता ना, ये जो गमला टाइप का लगता है उस पर ये करिएगा। नहीं, यहाँ देश में जहाँ परसेंटेज लिखा हुआ है 64% मेरे में, तो स्लाइड
वो
शो
मैंने
है।
कर दिया, वो मैंने कर दिया है।
लेकिन फुल स्क्रीन कहाँ आ रहा है?
मेरे स्क्रीन पे तो फुल है सर।
यहाँ तो नहीं है।
तो सर कोई और कंट्रोल तो नहीं कर रहा है उधर से? आप
नहीं
आनंद से
नहीं
बात
नहीं,
कर।
कौन करेगा, कौन नहीं करेगा।
नहीं नहीं, आनंद से बात कर लीजिए एक बार।
आनंद जी, ये स्लाइड शो में तो नहीं है
नहीं
आनंद?
सर, वहीं से प्ले नहीं हो पा रहा है स्लाइड। जी 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 सर, गुड इवनिंग।
ये स्लाइड शो में तो नहीं दिख रहा है।
प्रेजेंटेशन को बंद कर दीजिए एक बार, फिर से मतलब ओपन कीजिए।
बंद किया जाए सर।
हाँ हाँ, स्टॉप शेयरिंग करके, स्टॉप शेयरिंग कर
आप
दीजिए।
गाइड कर देंगे। स्टॉप शेयरिंग कीजिए, स्टॉप शेयरिंग कीजिए, पहले पहले स्टॉप शेयरिंग, स्टॉप शेयरिंग कर लीजिए। यहाँ पे इसे यहाँ से ऐसा मैं स्टॉप शेयरिंग को शेयर। वहां से करो ना, यहाँ अरे कोई हड़बड़ नहीं, इतना हड़बड़ मत दिखाओ यार, थोड़ा आराम से काम। स्टॉप शेयर लिखा है, शेयर तो कर दिए। शेयर करो, वहां से शेयर करो। ये क्या हुआ? शेयर तो किया हुआ है। हेलो। आ गया आ गया।
हाँ, दिस दिस इज जो है स्लाइड शो या।
अब ठीक है, चलिए ठीक है, चलिए।
So I would request our Dean ICP to say a few words before we start the session. Tiwari sir.
क्या भूल के गए मुझसे पूछे, क्या भूल?
Already it is 7:30, sir.
Okay, should we start now? Or you can wait for a minute.
Honorable Dean, Dr. Professor Kamlesh Tiwari sir,
ये मेरा
our
स्लाइड
short certificate course is going on, taking the several classes, and this time our master teacher is none other than Dr. Sudhir Kumar, and he is known to be the first respiratory physician of Bihar, as he had joined as assistant professor in IGI MS Patna. And there we know that he is the person who has set up this respiratory medicine in Bihar. He has also was the chief of the chest forum. And for years, from 1999, he has started this program, and now he has been so many we can say the office bearer of this Indian Chess Society, and now the president of National Indian Chess Society. And he's also the organizing secretary of NAPCON 2020-25. And he has got several awards on us, the inspiring pulmonologist of Bihar. He is MBBS from Varanasi, BHU, MD from Varanasi, DM from, he had got training in this respiratory medicine as junior resident, etc. from Chandigarh also. And he's a very good orator. And over to Dr. Sudhir Kumar. And his topic today is ABPA. He's a very much expert in this. He has given the oration on this. So over to Dr. Sudhir Kumar over your talk on allergic bronchopulmonary aspergillosis, some topics like aspergilloma or invasive Sudhir Kumar.
Thank you, sir. Thank you for such a elaborate and kind introduction of mine. And I know the pulmonary medicine is much before my coming to Patna.
Your face is not visible, Dr. Sudhir.
Sir. I okay. Let me see. Check my video.
Yeah.
Am I visible, sir?
Yeah. You
Okay,
start.
right, sir. So, so the topic is basically on pulmonary aspergillosis, and it also includes allergic bronchopulmonary aspergillosis. We have given more importance to ABPA because in day-to-day practice, we actually confuse ABPA with tuberculosis. It is a great mimicker of tuberculosis in view of considering the point that it has got radiological too much similarity with tuberculosis. And it also behaves many a times clinically like tuberculosis with like fever, cough, expectoration, and hemoptysis. So, and when you have a radiological abnormality with hemoptysis, and that is similar to tuberculosis, then most of the physicians would start empirical treatment of tuberculosis for ABPA. And it is very important that even in my lifetime, I have actually treated few ABPA patients in relation with tuberculosis. And slowly I learned with time that how to actually quickly diagnose ABPA in a suspected patient of tuberculosis. Even one patient, I admit that I had put him on MDR TB, and subsequently after 2-3 months, I realized that I was going in a wrong way. So anybody can do mistake, and there is no such big deal in this. So what is why I'm not to move this? Next, okay. So basically, this aspergillosis is a spectrum of diseases, and many of the diseases have got overlapping symptoms and even overlapping radiological abnormality. So it begins with very simple aspergilloma, and it can go to very severe invasive aspergillosis. And it's a great spectrum. In between, we have chronic cavitatory aspergillosis, or what we call chronic pulmonary aspergillosis. And this chronic pulmonary aspergillosis has got different types. It can be either invasive, not acute, but subacute, chronic cavitatory, chronic fibrosing, chronic necrotizing. Then one form is aspergillus nodules, and then it can be tracheobronchial aspergillosis. It can be simply bronchial aspergillosis. So different types of aspergillosis there, but our topic would be dealing with the common ones. Then what are the common ones? The common ones are chronic pulmonary aspergillosis, which is usually cavitatory or fibrosing or both, simple aspergilloma, allergic bronchopulmonary aspergillosis. So these would be dealt more in detail. So as I have already introduced, these are the different aspergillosis syndromes, and everybody knows that invasive aspergillosis is basically an immunocompromised host, and there may not be an underlying lung disease, and it is basically in the patients of neutropenia or non-neutropenic immunosuppression in patients of advanced HIV, T cell suppression, corticosteroids, solid organ transplant, and this stem cell transplant recipients. Whereas the chronic pulmonary aspergillosis have got different forms, and these are mainly found in non-immunocompromised hosts. So basically, they will have previous underlying lung disease in the form of, previous tuberculosis, cavitatory tuberculosis, fibrotic tuberculosis, emphysema, COPD, and so on. Then we have got allergic bronchopulmonary aspergillosis, which again is an immunocompetent host. and these patients are hypersensitive to Aspergillus fumigatus. And the predisposing factors are asthma, cystic fibrosis, COPD, and bronchiectasis. So, what exactly is allergic bronchopulmonary aspergillosis? Basically, it is an immune reaction which is mounted against this Aspergillus fumigatus, which leads to a pulmonary disease because of its colonization of the airway. In COPD patients or chronic lung disease like asthma, cystic fibrosis, bronchiectasis, and COPD. Initially, the criteria was only limited to asthma and cystic fibrosis, but recently some papers and some case reports did found that even in bronchiectasis and COPD patients, they develop ABPA, and this is possibly because of ACOS also, in which COPD and asthma is there. And even in bronchiectasis patients, some of the patients actually react to, because of the chronic colonization, they tend to develop allergic bronchopulmonary aspergillosis. And rarely it can even occur without any predisposing conditions like asthma or clinical asthma, but it is also known that it can still, the patient will eventually in due course of time develop asthma also. So initially there may not be any predisposing condition, and actually ABPA may make the first presentation of asthma, or it can actually delay, not delay, but actually precede the presentation of asthma. So maybe I would, if time permits, I would show one case of such in my presentation. So different guidelines were had come up in the past 25-30 years, but the latest revised diagnostic criteria ABPA has been given by the Isham group recently in the year 2024. So if you see here, in patients with, they have included bronchiectasis and COPD in their criteria as a predisposing condition. And they have said they have decreased the criteria of total serum Ig. Initially, it was 1,000 or more. Now they have decreased to 500 only. Basically, they found that many patients of ABPA were being actually missed out or not treated, because when we put it on the Ig criteria, they were not satisfying it, and those patients actually did not get the advantage of ABPA treatment, even though truly they were behaving like an ABPA. So to increase the sensitivity, they had lowered it down. And while the specific Ig against fumigatus remains the same, that is more than 0.35 or 0.35. Also, apart from these essential components, now the patient should have at least 2 of the remaining 3 criteria. So one is positive IgG against Aspergillus, PBE, which is more than or equal to 500 cells per microliter, and the HRCT should be consistent with ABPA. So how they have defined is that either they should show bronchiectasis or they should show mucus plugging, and more importantly, high attenuating mucus, or what we can have. If that is present, that is pathognomic and diagnostic ABPA. In fact, they have given at one place that if you have got only ham in a patient, then you don't need to fit into other criteria. You can straightway assume that the patient is having ABPA. Even other criteria may not fit into the as detailed in this slide. So, or they will have fleeting opacities on chest radiograph consistent with ABPA. So this is one of the characteristics of fleeting opacities. On different time frame, they have got opacities occurring at different places. Now, there are certain important considerations that you need to consider. These are that once you have got a finger in globe, I will show you this finger in globe appearance, and then fleeting opacities that I will show. And the expectoration mucus plug is like a bronchial cast. So this is also one of the suggestive features of, or pebble-like for ABPA. So there are certain criteria. For India, the cutoff value is for IgG is more than 27, whereas in different population, it may differ. And here you can see in a footnote, they have written high attenuation mucus is pathognomic of ABPA, and it confirms ABPA diagnosis even if all other criteria are not fulfilled. So They have given a radiological classification, and that is ABPA serology, that is serology positive without any bronchiectasis. Meaning thereby, they may show transient opacities, but they will fade away without having any underlying chronic, chronic lung changes. So, another will be ABPA with bronchiectasis, and third will be with mucus plugging. So they have differentiated mucus plugging with HAM. This is just to and the purpose is that this HAM needs aggressive treatment, whereas mucus plugging actually do not need so much of aggressive treatment. Similarly, the another they have again included is chronic pleuropulmonary fibrosis. Okay, initially it was included way back, maybe even more than 10 years back, it was actually there. Then the Isham had excluded this because they were not very sure of that. However, in my clinical practice, I've been seeing these type of patients quite frequently. And so I never agreed to the Isham criteria when they had excluded it. And you can very well see now that they have again re-included that if the patient has got pulmonary fibrosis, fibrocavitate lesions, fungal balls, and pleural thickening, then this is one group which needs to be taken care, and there has to be a treatment plan for these type of patients. So you see one of this patient, you can see two X-rays. If you see here, I don't know whether you can see my pointer or not, but if you see that there is a change of pattern. Here is a shadow, small shadow here. Then at another time, the shadow has fleeted from here, and they can see another shadow has occurred here. So this is very typical of fleeting shadow. And then this again, it has partially resolved, and this shadow persists. So it's a typical of fleeting shadow. What was the clue in this patient? If you see here, it was eosinophilia. 14% of eosinophilia was there in this patient. This has to be the first clue in your clinical practice. So as I have said, everybody does this mistake. I have done many a time. So here, this patient was treated with arsenex, and he was almost on the verge of completion of the treatment, and still the patient was not improving. He was put on ATT, very common. Everybody will do it. Please don't feel that you will never do it. So here it is. Here you see the HRCT of this patient. Now I will tell you, this is the globular appearance. Okay, globular appearance. And if you see here, this apparently is one type of finger in globe appearance, and this is mucus plugging of the dilated bronchi. So we can appreciate the bronchi, dilated bronchi or bronchiectasis here. And same, the coronal section, you can very beautifully see the bronchiectasis, which is central, and then consolidation and nodules and TIB over here. And you can see the finger globe appearance, the two fingers here, adjacent to each other. Branching bronchi, which has got mucus plugging adjacent to each other, and they appear as a finger globe appearance. So this was quite characteristic of ABPA, and the most important clue in this patient was that here you can see that there is high attenuating mucus. How do we assess it is high attenuating? You have to compare it with the mediastinum, and then you are also to compare with the soft tissue here. You can see that attenuation, let's say here, the attenuation, this part is having this much density, soft tissue density, but this part, the another dilated bronchi adjacent to this is showing high density, which you can see that it is almost reaching to bony, slightly less than that, more than this. Same is here. You can see it. And also here, partial, and then normal mucus here. So this is high attenuating mucus, which is pathognomic and diagnostic of ABPA. So what I did, I got the IG done, which was 11,800, and the Aspergillus fumigatus IG was 0.60. So the diagnosis was confirmed because of eosinophilia, which was more than 500, and these two other criteria, and they're very characteristic, HRCT pattern. Even if we had normal these patterns, these tests, because of the HAM and central bronchiectasis, the diagnosis will still be ABPA unless ruled otherwise or proved otherwise. So here, that was the CT scan, a reporting done by a qualified radiologist, and that is why we pulmonologists always say that we should know the pulmonary we should be pulmonary radiologists also. So here they have missed the hand, they have missed the diagnosis, they could not suggest a diagnosis, and they gave a diagnosis of POX, the more likely differential. That was their final diagnosis. So here I have written my comments and I have conveyed this comment. The radiologist, we always share with each other whenever I find that, yes, something should be shared with the radiologist. I always tend to share, and it is for the benefit of the patients, for the benefit of our profession, and similarly they also share with me certain points which I usually miss. So that should be the way how we should practice. So how do we treat a patient of ABPA? They have said that treating asymptomatic ABPA patients with systemic therapy is not recommended. True, if they do not have bronchospasm, do not have cough, do not have shortness of breath, and they had eosinophilia, and they had other criteria suggesting ABPS, but they are totally asymptomatic. Sometimes they simply have allergic rhinitis and they come to you, and then you tend to get that patient. Sometimes they have got radiological abnormality and still you diagnose with PA, which was done because of some other cause, and then the patient is actually not having any respiratory symptom. So there they have recommended not to treat this patient with systemic corticosteroid or antifungal agents. But here one point I would like to say, it is not a blanket statement. When you have got a patient, asymptomatic patient with bronchiectasis and with HAM, that means that ongoing insult is too much and it is going on. Even if the patient is asymptomatic, the patient is likely to deteriorate and likely to have more structural damage and bronchiectasis with due course of time. And in such patient, you must treat those patients as it should be treated for ABPA HAM group. Now, ABPA should be treated with systemic therapy only if there is a poor asthma control with the standard asthma therapy. And this is true. The same happens, or if the patient has got recurrent recuperations despite asthma therapy, such patients should be put on systemic therapy. Now, what is the systemic therapy? That is low dose or maybe moderate dose of 0.5 milligram per kg per day for 4 weeks, which should be tapered completely over the next 4 months. And or oral itraconazole therapy for 4 months is recommended as an initial therapy for treating acute ABPA. Now, what they say is here what is acute ABPA is not acute exacerbation of ABPA. It is an ABPA diagnosed which is having acute symptoms or having symptoms which is ongoing. So here, this is what is the meaning of acute ABPA. Now, when is oral itraconazole recommended? When one is as an initial therapy, when systemic corticosteroids are contraindicated because of some reason. Either the patient's sugar is uncontrolled, or the patient is having glaucoma, or the patient is having osteoporosis, or the patient is having acid peptic disease, and so on. So, in such a situation, you can use oral itraconazole. When a combination of these two should be done as a first-line therapy for acute ABPA, initially it is not a choice. But if you are using oral itraconazole as a primary agent, then for symptomatic relief early, you can use a short course of oral corticosteroid, which should be not more than 2 weeks. Now they have said that ideally we should not use oral voriconazole and other conazole as a first-line therapy. They should only be used if there is any contraindication to systemic glucosteroids and when they are intolerant or there is a failure or resistance to the itraconazole therapy. So they also again say that the high dose ICS should not be used as a primary therapy. Just that the patient has got ABPA, that doesn't mean that we should increase the inhaled corticosteroid. The dosing of ICS should be according to the guidelines of asthma treatment. So they also say that we do not use or recommend biological agents as a first-line therapy for initially diagnosed and symptomatic ABPA patients. And that is true because biologicals are always a second-line therapy in those patients in which the standard treatment of ABPA is not giving a desired results, and the patient continues to have symptoms and they continue to have acute exacerbations. So how do we monitor? Once after 12 weeks, we monitor the patient according to the radiology, clinically, symptomatically, and based on IgE response. So IgE should reduce at least by 20% of the initial level. That is sufficient to tell that serological they are responding, and radiologically if they had any sort of radiological infiltrates or transient consolidations, all they should have vanished, and there should be improvement in the symptoms too. We should never monitor based on IgE and IgG levels, which is specific to Aspergillus. Neither it is to be monitored with eosinophil count. So this should be very clear that we are not going to monitor with these parameters. If possible, the therapeutic drug monitoring while using azoles is recommended, but in our setup, possibly we are not able to do that, at least in our setup, that is in Bihar, most of the time. So how do we treat exacerbations? The treatment of exacerbation is basically in the same manner as newly diagnosed ABPA, and here they have recommended the combination therapy. In acute exacerbation of ABPA, they have recommended a combination of prednisolone and itraconazole. And they also said for any ABP exacerbation, one should never use, nebulized amphotericin B or something like biological agents in such patients. Once the patient they become steroid dependent or treatment dependent, whenever we try to reduce or remove the systemic therapy, the patient relapses. In such patients, it is said that we can try long-term itraconazole, that is more than 4 months. And we can also try biologics in these type of patients. And what are those biologics? Just let me mention, those are mepolizumab, then bendalizumab, and then omalizumab, or nebulized amphotericin B. It is in this group of patients where this type of treatment, these modalities have been recommended. When the patient is in remission, and then the only thing is that you have to manage it as an underlying asthma score and bronchiectasis. Like if the bronchiectasis is causing some symptoms independent of ABPA, then that should be managed. And for patients who have achieved remission on antifungal or biological agents, then periodic assessment are recommended to determine the need for these therapies. Whether they still need it or not, that should be actually assessed. Now, if the patient has got extensive bronchiectasis, respiratory failure, cor pulmonale, right heart failure, and advanced ABPA sort of thing, then we need to use the standard guidelines for how to manage it. We should add like long-term oxygen therapy, vaccination, and if the patient is willing, then the lung transplantation, or if the patient is fit for the lung transplantation. So we should be advised these modalities in these type of patients. So let's come briefly on aspergillosis, pulmonary aspergillosis. The one which is very deadly is invasive aspergillosis. So these patients actually, you should be very careful if the patient develops acute respiratory pneumonia sort of thing or infiltrates in a patient showing well circumscribed dense lesions with halo sign or air crescent sign or multiple cavitatory lesions or bird nest sign. If these signs are there on the CT scan and the patient is actually having a history of neutropenia or stem cell transplant or too much of steroid exposure, or there is a T cell immunosuppressive agents are being used like tacrolimus or cyclosporine. So in this type of patient, in this background, if you get a clinical and radiological compatibility of this, and if you get on bronchoalveolar lavage or maybe sputum, if you get a sample showing fungal elements or they show grow aspergillus on culture, or you get a detection of the antigen like galactomannan in serum, plasma, or BAL, then probably you are dealing with invasive aspergillosis. So in such type of patients, if you see this is a typical microscopic picture where you see a branching pattern of aspergillus where they are making it, and the branching is acute angle. So if you find these type of picture in the cytology or biopsy specimen, this is diagnostic of invasive aspergillosis. So now coming to tracheal bronchial aspergillosis, this is a actually CT imaged reconstruction of the airways, and this shows the aspergillus inside it. And what is the clinical criteria? One is that they should be having some immunocompromised condition as it is for invasive aspergillosis, and they should have chronic symptom. It is not an acute situation like invasive. It is a chronic symptom. The duration would be more than 3 months with typical symptoms of tuberculosis. And then in radiology also they will have actually radiological lesions which is quite similar to tuberculosis. However, the catch point is that they will have a predisposing condition of immunocompromised state. And then how do we diagnose it? We should have a positive result of positive IgG and aspergillus, or we should have the species identified on lavage or bronchial lavage or pleural from the pleural cavity. Then obviously other parameters, the inflammatory parameters are likely to be elevated, and we should be able to exclude other pulmonary pathogens. That is simply meaning that the tuberculosis and other bacteria should be excluded as far as possible, including other fungi and mycobacteria. So now coming to chronic pulmonary aspergillosis, this is the typical, bookish picture of chronic pulmonary aspergillosis. You will have architectural distortion, cysts, and then fibrosis, fibrotic nodules, bronchiectasis, and a consolidation, fibrotic, consolidation leading to large fibrotic nodule, and may or may not, they may have a cavity in which you may have aspergilloma, like here we are seeing an aspergilloma here. So if you see here, there is bronchiectasis, there is destruction with these, and here is an aspergilloma. So this is typical picture of fibrosing chronic pulmonary aspergillosis. And this is another picture where there is emphysema here, actually, which is, and on the other side, they have got a large, probably old tubercular cavity, and there is a aspergilloma. So sometimes a patient overlap. That's why I had shown an initial slide that the patient may have aspergilloma and then they may progress to subacute invasive aspergillosis, or the patient may be having CPA or invasive aspergillosis or even ABPA, and they may develop subsequently aspergilloma. This Aspergillus bronchitis is another condition, a new condition now described, which is similar to tracheobronchial aspergillosis. The only difference is that they are in a non-immunocompromised patient. That is, immunocompetent patient, usually with bronchiectasis or cystic fibrosis. So the treatment, basically, the diagnostic criteria would be the similar as with the tracheobronchial aspergillosis, and the treatment would be almost similar. However, in this, the treatment is of shorter duration, but there is a catch point that these patients most of the time recurs. That's the problem recurs in this Aspergillus bronchitis. The treatment in this patient would be itraconazole or voriconazole for 4 months, but the relapse risk is up to 50% of these patients, and many a time these patients may need long-term therapy. What is the treatment of invasive pulmonary aspergillosis? In this, it is there is improved survival with voriconazole, and it can be given initially. It should be given intravenously, and alternatively, you can try liposomal amphotericin B. However, the all-cause mortality, despite best efforts, minimum mortality rate is 50%. Treatment of IPA should be continued for minimum of 3 months. And it all depends on the duration and the severity of underlying immunosuppression and the clinical response to therapy. The treatment of tracheobronchial aspergillosis is similar to IPA. And it continues to, and the same treatment plan has to be done for TBA. Treatment for chronic pulmonary aspergillosis like cavitary or fibrosing, they should be treated, since it's a chronic problem, so they should be treated for a minimum of 6 months with itraconazole. However, in certain patients, if the response is not there, you can use voriconazole in these patients. Whereas the patients, if they develop subacute invasive aspergillosis, they should be managed as invasive aspergillosis. If they develop subacute invasive aspergillosis, they should be managed as invasive aspergillosis. We all know the ideal treatment of aspergilloma is surgical resection. That is the only definitive therapy. However, in those patients who are either in respiratory failure and because of some reason they cannot be operated, then intracavitary instillation of amphotericin B is another therapy, especially to control the symptoms like severe hemoptysis. And then symptomatic treatment can be there. You can also try bronchial artery embolization in these patients as a life-saving measure before surgery as a definitive treatment. So I think if I have not taken, I may have taken longer time than prescribed. So thank you very much for listening to this short presentation. And I give my over to Dr. D.P. Singh.
Still, we have got a lot of time. This is a 1 hour talk, and there should be question answers. And so I would request our delegates and attendees to put up questions on the chat box, and our experts and speakers would gladly answer your questions. Yes. In the meantime, if there is a question should come from our audience. Dr. Sudhir, so when we suspect this, especially ABPA, in the cases of asthma or COPD or cystic fibrosis, when we suspect at the diagnosis, because a case of asthma, and what are the points that you will suspect that this could be a case of ABPA?
Correct, sir. So it starts with the historical aspect. Actually, if the patient of asthmatic patients come to you with expectoration of bronchial cast, pebble-like hard structures, then it should be the first pointer. I mean, everybody doesn't have. Almost only 10% of the EBPA patient will give you this history. And sometimes they miss it. Sometimes they themselves say. And that is very rewarding. When they say themselves, I immediately say that it is more likely to be ABPA. So another important history would be that the patient develops hemoptysis in an asthmatic patient. So here I immediately think that I must rule out ABPA. Obviously, tuberculosis would be always a DD in the such type of patients. Third is that if any asthmatic patients, when they have got exacerbation, or even on the first visit, if we get a chest X-ray done, clinically they are fitting into asthma diagnosis, but the X-ray shows any type of shadows. It can be infiltrate, it can be consolidation, it can be collapse. Or it can show even bronchiectasis. So if these type of things are there, and I think of ABPA. So, and fourth would be if the patient has got high IgE and high peripheral blood cytophilia in an asthmatic patient, I would try to screen those patients for ABPA by getting Aspergillus fumigatus specific IgE done. So if that is high, then we have detected a case of ABPA serological stage, in a serological stage. So and fourth or fifth would be patients of tuberculosis being treated for tuberculosis and not improving, and they are not actually having a positive AFB on a sputum or on gene expert. So they don't have that background, and they are being empirically being treated on the base of clinical and radiological abnormalities and their symptoms. So these type of patients, I would think that they might be ABP.
Thank you, Dr. Sudhir. One of the question is co-infections of ABPA with tuberculosis, how to manage?
Correct, sir. One is that co-infection. I have my case also published with this co-infection TB with ABPA, and one of my case was patient of COPD, bronchiectasis, MOT found positive, and also ABP. So one of my patient was like this. So it is said for Indian guidelines, if you see, they always say that any patient with radiological abnormality having ABPA, then you must rule out tuberculosis, because both can co-infect, because the prevalence is quite high of tuberculosis. So once they have got tuberculosis with ABPA, the first part would be that you try to avoid steroid, at least in the initial part, when the maxillary loads are high. So you give ATT, and you give standard asthma therapy. You may add actually itraconazole, even though there would be drug interactions with rifampicin, but you may add if you feel it is needed. And then initially you try to keep the symptom control for asthma and ABPA. At the same time, you aggressively treat and appropriately treat tuberculosis simultaneously. And maybe after 1 or 2 months, possibly, if the tuberculosis is well controlled, there is no SF5 bacilli detected, gene expert is negative, and the radiological clearance is there, you can go ahead with the standard therapy of ABPA as per the guidelines.
That's a very nice answer. And I would request Dr. Dr. Sanjay Kumar, to say a few words or have interaction. Dr. Sanjay? No? Dr. D. Nath, are you here? Dr. D. Nath? How do you manage this patient in case of amphotericin B induced nephrotoxicity? That is one questions on the chat box. Dr. Kithana, how should we manage this patient in case of amphotericin-induced nephrotoxicity?
I think if there is a nephrotoxicity, we should put the patient on voriconazole in such patients, and at the same time, we should aggressively treat with the systemic corticosteroids. Because if you are implying that a patient is being treated for aspergillosis by amphotericin B, and the patient developed nephropathy on and renal injury, then I would suggest to switch over from. In any case, it is not the first line treatment. It is only reserved if the patient has got some issue with voriconazole or ketoconazole, atraconazole, especially in invasive aspergillosis or subacute invasive aspergillosis.
Okay. Dr. Sudhir, have you got any multiple choice questions? Because you have to put this to our PGs and to our others, multiple choice questions in your topic.
Okay.
Yeah.
I'm really sorry you had once mentioned this.
Yeah.
And it went out of my mind truly. And if I would like to ask some questions, I would say that let's say that a patient comes to you with a history of being treated as tuberculosis, and the patient's symptoms are not being improved. I would say, let's say they are AFB positive also, and that the patient has a lot of cough, breathlessness, and sometimes maybe some of the radiological shadows are also not improved. And the patient might be having fever too. In such a situation, how would you suspect, and why would you suspect ABPA also in those patients?
So
one choice would be
audience.
one choice would be history of clinical asthma. Another would be persistent or recurrent peripheral blood eosinophilia being detected. The
So that
patient
could be the clue that if
uh,
we get the peripheral eosinophilia,
hmm.
if there is a fleeting shadow, that's a very common
Yeah,
radiological fleeting
so
shadow.
these if they are being treated and still they have got fleeting shadows, their tuberculosis may be well controlled actually, but then once they have these are the clues that you may have ABP. And
So
any more questions? How many students are actually there, or PGs are there, or
more than so more than 40 participants was in this chat box. Participants are there.
Great.
Just
So I received from 40
from,
only 3 or 4 questions have come.
just we should inspire that questions should come, and otherwise you should have
Either my presentation is too bad or it is too good that they have understood everything, or they have not understood at all. Because if it is the ideal one, then the questions keep coming.
So if there is no questions, then we can conclude. As we conclude this beautiful lecture, very enriching lectures on ABPA by our friend Dr. Sudhir Kumar, I would like to take a moment to reflect on the key takeaways from our discussion. We have explored the complexities of ABPA and pulmonary aspergillosis from basics to the latest advancements in diagnosis and treatment. We have also discussed the challenges in managing these conditions, particularly this itraconazole or steroids, when to use it, whether we should use it combined whenever there is acute exacerbation, but otherwise guidelines say the itraconazole or azoles is the main therapy in the treatment of ABPA, and steroids should be added later on Steroid is the treatment or itraconazole is also the treatment? First line?
The first line is steroid actually.
Steroid, yeah.
However, I mean, if at all it is required, and
Yeah.
however, you may try. It is recommended that as a alternative you can try.
Hmm.
That is your choice also. But then it all depends how much effective it is. And
But
secondly, you should try it if the steroid is not giving that result, or if the steroid is contraindicated for some reason, then itraconazole should be the first choice.
But in the acute case of exacerbations of this, you can
Both has to be combined.
Withdrawals and the steroids.
Has to be combined, and the steroid has to be given for 15 days.
Yeah. So I would like to express my gratitude to our esteemed faculty for your expertise and insights, and to all of you, our participants, for your active engagements and thoughtful questions. All of you, your enthusiasm and dedication to learning are truly inspiring. And as we move forward, I hope that knowledge and skills you have gained from this course will enable you better diagnose and manage the case of ABPA and pulmonary aspergillosis. Especially, you have shown the beautiful pictures of aspergilloma or the invasive aspergillosis and others, and also the management of all these cases, the aspergillus, bronchitis, etc. In conclusion, I would like to leave you with a message of hope and optimism. With the continued advancement in medical research and our collective efforts, we can improve the outcome for patients with ABPA and pulmonary aspergillosis. Thank you again. And next Wednesday, we are going to meet, and our talk will be on sleep disorder breathing, OSA, and our learned speaker will be Dr. Saket Sharma. So thank you very much.
And is somebody is asking something, or maybe want to say something.
I have a question.
Yeah, role of fungal culture sensitivity if non-responding patients. Yeah.
Yeah, that is what exactly, what they say. If you the patient is not responding to itraconazole, then you need to get a culture done. Anna, you should also assess the serum level actually, whether they are into the therapeutic range or not. So both the things are required. The patient may be sensitive, but the serum levels are not going to that level, so it is subtherapeutic. Or the patient may be resistant. In such a case, there is a definite role of fungal culture and sensitivity. Otherwise, how do we know? The only thing is that we don't have much of choices. We have got 2 or 3 choices apart from itraconazole. So even if you don't get it sensitivity done, you can switch on to the voriconazole. You can switch on to the liposomal amphotericin B, or you may even give nebulized amphotericin B. But the point here is that if you feel that the patient may have resistance to the fungal treatment or fungal medicine or itraconazole, then you can obviously try to get a fungal culture and sensitivity done, and you see which one is responsive, and out of our choices, you choose the best possible for the patient with minimal side effects.
Thank you, Ankit, for your questions. Anybody can ask. Still, we have got 10 minutes time. Yeah.
Sir, in clinical practice, how frequently do we encounter itraconazole resistance?
Actually, I would say rarely, because most of the patients of our in my practice are controlled on these treatment, and in fact, I might have missed some of the resistant patients. That is also true, but I have not got a culture and sensitivity done. So maybe this lecture would make all of us more sensitive and more proactive in getting a culture and sensitivity done if the patient is not responding to what we desire. I mean, the patient do not show a good response and they continue to have exacerbations and symptoms. I think in such patients we should get it done.
Thank you, sir.
So If there is no questions, should we close the session?
Thank you, Dr. DP Singh, sir. I must thank you. I mean, your dynamism is too, infectious. And however, I might have tried to match you in last 25 years, since we know each other from 1999. I have never matched you till now. And I don't hope that, it seems that you are a person from Mars. The energy that you are everywhere, omnipresent, seeing more than 150 patients a day, and still delivering lectures, organizing seminars, CME,
No.
conferences, and so much of your academic input. I think we have taken a right decision to actually make you our patron of the National Pulmonary Conference. I could not find anyone else better than you to be patron of National Pulmonary Conference, that is NAPCON 2025, which is going to be held in Patna. So
Dr.
we
Sudhir,
are blessed. We are blessed.
Dr. Sudhir, this is the dream project of our Dean, Dr. Kamlesh Tiwari, sir, for the short course the certificate course on respiratory medicine and many other topics, 5 more topics. And I would request you to write this brief write-up of this talk and at least 10 with this objective questions, and that will be published in the APCON 2026. So we are going to write the book on.
Okay, that I will do.
Thank
Sure.
you, Dr. Sudhir, for the very nice deliberation, and we have enriched in the management diagnosis of ABPA and aspergillosis, pulmonary aspergillosis. Thank you so much in joining this as a master.
Thank you, sir. Thank you. Good night.
Good night.
And good night, everybody, every students, PG students, and all my juniors.
Okay.